Good afternoon. It certainly is a pleasure for me to be able to introduce our speaker this afternoon. Kim Mooney is a certified thanatologist. She's the founder of Practically Dying, and she has worked for 26 years with individuals, families, and organizations, providing education and support on end-of-life and grief topics. Kim is a community educator for a number of end-of-life initiatives, including the Conversation Project in our community, and serves on hospital and hospice ethics committees. Prior to founding Practically Dying in 2014, Kim worked for more than 2 decades with hospice organization at the local, state, and federal levels. During those years, she cultivated a broad set of skills in end-of-life care, grief crisis intervention, grief support, and recognizes that deaths of all kinds in all communities require different kinds of emotional, spiritual, and mental interventions. But she's also deeply learned that the most important thing about death is the life that came before it. It is a pleasure to have Kim with us today. Please welcome Kim Mooney.
Hi. So when you have a company named Practically Dying, and you go to a party, 2 things happen. There's a certain percentage of people who realize that they suddenly have to go to the bathroom and they never come back. There's an equal group of people who corner you and sit you down and want to tell you about every grief and loss and death that has ever happened to them because nobody's ever been willing to listen. In my work, I get to work with people on all parts of the health continuum. Very healthy people, people like us sitting here not thinking about things, we're pretty young, people who are dying, and people in all places in between. And I will tell you that if you get to the point where in your life you realize that learning about how death is a natural part of life becomes important, it changes your entire life. That's one of the things that I think we don't realize. We think, oh, we have a lot of cultural fear around death. Well, we do have cultural fear around death. But mostly what we have, I think, and anybody who does end-of-life care is going to agree with this, we have cultural ignorance around death rather than fear. Yeah, there's an initial fear to bring it up. It's sad, it's scary, we don't understand it. But the truth is, it's more ignorance because I got 100 people sitting in this room who want to hear about death and dying. So we're not afraid of it so much as we don't know what to do with it. And the other thing I want to differentiate, because I want to lay a little ground on end-of-life care here, is that more people are afraid of dying than they are of death. And when we start to break that down, we have different questions, and we have lots of different approaches to this. So skilled end-of-life experts, facilitators, know that if you open conversations about anything that is relevant to the people, that you have good information and you know what you're doing, you're actually going to change the shape of their life because there is nothing in the long run that is more interesting or important or compelling than the truth. And this is a truth that we're all living with. So I really appreciate you being here. For many of us in this room, this is probably a theoretical discussion. I know there are people in this room who've worked with MAID, medical aid in dying, or had family members or friends, and I'm hoping to speak quickly enough. I want to leave a lot of room for us to talk because it is the conversations that we learn from and start to change things. So there are 3 reasons why I really think this is important. The one that I said originally is that this does change the shape of our lives just because we need this information. But when you are willing to entertain the fact that you're mortal, you have 2 possibilities that come up at no other time in your life. And one of them is that you realize that you can stop the end of your life from being a runaway medical emergency. And most of us don't understand how easily that can happen in this country. A runaway medical emergency, which has the added negative effect of creating really negative legacies for your family. I ran grief support groups for 20 years, and I can't tell you how many people came back in and said, did I do right by Dad? Could I have kept him in a better situation? You know, all that fallout is really hard. So if you're willing to pay attention to this now, you have a really good chance of being able to avoid that. But the second piece that I think is equally as important is that if you are willing to entertain your mortality now, not just think about it, but really entertain it, it gives you an opportunity to live your life completely differently every single day. It gives you an opportunity to really live the life that you want more than you ever have before. Because you start to pay attention differently and you quit being careless. And that's really what this law is about. People who aren't looking at death theoretically, people who are sitting in it, people who are dying, are looking at what their life is looking at right now. What has happened to me as I'm dying? And what do I want these days to look like? Sometimes it's days. And they want the same things the rest of us want. They want a death that doesn't have pain at the end, that allows them to die without being in what they consider to be a terrible situation, and allows them to spend the rest of their life the way they want to, saying goodbye, you know, having time and energy to control it. Now, whether you approve of this law or not, because it is incredibly controversial, and it has been since it was passed in Oregon, it's really important to understand it because it is the biggest paradigm shift of our lifetime, I think, in healthcare. So the opponents of this law have maintained that what this law is doing is getting in the way of really good health care, that we should be focusing on other things besides allowing people to use this law. It's loaded. They call it physician-assisted suicide. That's what it was first called. And of course, we all know the word suicide is stigmatizing immediately. It's a loaded word. So when you think of things as suicide, they maintain that it's thought of as a sin sometimes. It's certainly thought of as a failure on the part of the person or their family or their health system, that person has failed. And it puts us on a slippery slope. And that slippery slope is that if we allow people to do this, it won't be very long before we'll be looking for ways to get rid of marginalized populations. The disabled community, for the most part, because there are no absolutes in end-of-life care. For the most part, the disabled community has spoken out against this because they feel like they will be marginalized, that their lives will be considered less than, not worthy. There's a concern that the frail elderly people will be gotten rid of. You know, they take a lot of time and energy. They're not going to be around that long anyway. Why do we want to put all that money into them? So this is the slope that the opponents of this law are really concerned about. All of these are always worthy things to think about. The supporters of the law feel like this is a long-awaited opportunity to get some autonomy back from the other slippery slope that we've been going through. So like the last 50 years, we've developed this incredible technology, CPR, all these ways where we can keep bodies alive beyond their natural life expectancy. So a body dies, we have ways, as we say in the industry, to prolong life or to prolong death. We can keep bodies going when someone may not be in there. So that's been, yay, in some ways. That's the medical system's default. And I'm grateful for it at my age, because if something happens, I want somebody to do everything they can to keep me alive. But for dying people, not so much. All of these technologies, the efforts are really good for people who are going to get their health back. But when someone's dying, these can be real burdens. So those are the slippery slopes on both sides. And so people who are in favor of it are looking for ways that they can be in charge of when things and how things are going to happen. So regardless of where you're at, it's a paradigm shift we need to understand. So we are the 6th out of 8 jurisdictions that have legalized this. There are probably 15 more states that are looking at it right now. And most of the laws across the states, I'm going to break down the function of the law, the structure of the law, and the function of the law, and how it's going now. And I want to leave plenty of room, like I said, for comments. So we're the 6th out of 8 jurisdictions. The laws are pretty similar in all the states. They vary a little bit between the states, but they have the same pretty much basic structure. And there are 4 requirements that make you eligible to take advantage of this law. One of them is that you have to be an adult and you have to be a resident of the state that you're living in, so resident of Colorado. The second one is you have to be terminally ill. And this is a pretty artificial construct. Terminally ill is usually Medicare determined, and that means 6 months or less. And we all know that it's pretty hard to predict exactly how long someone's going to live. End-of-life professionals do a much better job of that because they focus on it. And there's a significant study that still holds that most doctors prognosticate 5.3 times more than you have because they don't know what dying looks like. 5.3 times. That means that a doctor might tell you that you have 6 months and you'll be alive for 4 weeks. So this is a pretty big crapshoot that we're dealing with. Nonetheless, you have to have a diagnosis of 6 months or less. The third requirement is that you have to have decisional capacity. You have to know what you're doing. And that is part of we're going to talk about how this gets played out. So you have to know what you're doing, you have to understand the implications. And the fourth thing that's the most controversial is you have to be able to self-administer the drug. And there's a little wiggle room in what that means, but if you can't take the medicine on your own, then you're not eligible for this law. There's also criminal repercussions for family members that help, so it's pretty strictured in a lot of ways. So if you pass all of those eligibility requirements, you go to a physician, and the physician has to run you through a lot of an assessment. It's not an easy law in a lot of ways. So an assessment would be basically saying, Michael, you're coming to me telling me that you want to use this law. Tell me why. Tell me what's going on. Is there any other way that we can help you? Are you in existential distress? Do you have something going on physically? Pain management? We can help you with pain management. So this is the right law for the right person. But the intent is that there's a lot of assessment done up front to make sure that there's nothing else that can be done to help that person. I'm going to put in a plug for hospice here, because this is also one of the things that's kind of wrong with the law. 95%, I think, of patients who use this are in hospice, and they need to be. I think 100% do, for a number of different reasons. This law, I think that there are 3 parts to having a good death, and one is that the medical piece needs to be attended to. Well, we don't want these to be considered medical events. Medical piece, psychosocial piece, grief, that human experience is just as important. That's what people are left with. It makes a big difference. And the third one is what we call death mechanics. Death mechanics are, where are you going to go? What's your life insurance going to do? How are you going to get rid of the body when this is all over with? And I'll tell you very briefly, one of the women, this is a great story, it's a horrible story. One of the first people to use this in California, got the medication, all good, beautiful, got her family and friends together in a park, had a beautiful going away ceremony, ritual, said goodbye, and then she died very peacefully, and her friends stood there and said, where do we take her body next? Never thought about it. So this law covers that one medical piece, but it doesn't cover the rest of the death mechanics. That's one of the biggest issues. There's no built-in support, psychosocial support or real support. Hospice provides all of that, which is why we want people to be in hospice and to get that kind of care so they don't have to think about it. Okay, so people sit down with their doctor. Doctor agrees that this is this is the right decision for them. Then they have to find a consulting doctor who agrees with the diagnosis and the prognosis. And if there's any question at all about whether the person's got capacity, they'll do a psych eval. Third, they have to find a pharmacist. 3 professionals have to be involved in this. And again, there's nobody who's ever required to do this. No physicians, nobody. So that's a lot of work for a dying family to be putting this out. People get the medication, almost half of them don't take it. It's psychological insurance that they have it. And we can talk more about the medication itself if we want to in a couple minutes. But it is psychological insurance for a lot of people. I was going to say about the rest of that process is that the first year, okay, so here we go. First year we had 52 prescriptions that were written. This last year we had 125. The first year we had 56 prescriptions, 72, I'm not sure the numbers. The increase has been 56 to 86. So we're seeing more people use it. Compassion and Choices is an advocacy group, and that's all they do. They've been working with this in every state. We have brochures on the tables that you can take home to read more about this. By the way, my business cards are on the table. Nobody ever throws my business cards away. Look at the back when you get a chance. You will not throw them away. So Compassion and Choices has done a lot of formal education around this. Talking to systems, trying to get people to understand that it's not, against the law, whatever. The first year, there was a lot of formal education. The second year, a lot of this is happening on the ground. Patients are talking to their doctors directly. Doctors have now heard of cases. They've gotten support around cases. More doctors are opening up. There's still a lot of physicians and medical people who are saying, whoa, I wasn't trained for this. This goes against my philosophy. That's always going to be there. This is not going to be the most popular topic in the world. So we've seen some expansion in the second year. We've got a couple of big health systems on board, so patients who are in those systems, Kaiser, UC Health, BCH, Denver General, I'm trying to think of what they are. Those patients have more access. They are eligible in the systems. They're not out there trying to find doctors on their own, which is, as I said, a whole lot of work. We're sitting where most of the other states were at the end of their second year. And, I think the most important thing is to understand this is a good starter law. If you agree with it, it's not a great law, all told, because it's got big holes in it. There are populations who cannot access it. And in all of end-of-life care, who are we really worried about and leaving out are the dementia populations who won't have capacity, who won't be able to do this. So it's not a fair law yet, but it's a starter law. That's the way I would describe it. And a lot of people are interested in it. I'm going to throw this open because I'd rather hear from you. I can talk forever. I'm Irish. Yes, sir.
Do you have any percent of people who die unexpectedly as opposed to people who know ahead of time that they're going to die?
10% of people in this country, thank you for starting with an easy one, 10% of people in this country die suddenly, either in accidents, heart attacks. They're never going to be in a medical system.
So would I just go to my primary care physician, or is there somebody that is there a specialist or somebody that has some, basic training to do this initial assessment, or do I just go to my primary care?
The docs who are in the systems have been more formally trained. They know it. I think people should start with their primary care docs. And part of the reason is ideally, we want the person who's assessing you to know you really well, to be able to ask questions not about what they see medically across the table, but what's been the trajectory of your life? What's the quality? What do I know about, you in general? So yeah, I always tell people start with their primary care.
What are the other states that have this law or something similar?
This is a memory question for someone over 65. Oregon, Washington, Montana, Vermont, California, Washington, D.C., and Hawaii.
Thank you.
So,
You may have spoken to this. What effect does this have on payment of life insurance?
That's a great question. And let me spend a minute and tell you something that's really important. The difference between medical aid and suicide certainly depends on how you view it philosophically. But suicide is usually very traumatic, and it's usually violent. And the people who are committing suicide are doing it on their own, and they're isolated, and it's traumatic for their families. Medical aid in dying is legal, and it gives people an opportunity to be a part of the process. People have a chance to find their way with it, families and friends, and it's not traumatic. On paper, legally, this is not suicide. There was actually work around this to make sure that this isn't considered suicide in Colorado. However, there are always going to be sticky parts about some of the laws. So if you commit suicide in Colorado, your health insurance, most health insurance companies will not pay you for at least the first year. If you use medical aid in dying, they have to pay. That's the line that's been drawn. This is not considered suicide for that. So you won't be dealing with problems with it if you use medical aid in dying. Truly. Now you might have to hassle with it. I mean, that's what I mean. This is on the ground. We're still working it out. Yes, sir, more. I can't hear you. I'm sorry.
Hello? Okay. I've been in practice here for 30 years. And one of the issues I'm running into is that some of my patients, as they see their loved ones develop Alzheimer's, which is a terminal disease, that is not considered a cause to do the self-assisted death. And I talked with the people from Oregon about it, and I was kind of shocked because we're seeing a high incidence of Alzheimer's. And when you see these families take in their partner and have to do self-care every day for 10 years because of the finances, it's just unbelievable. And so I see where someone has to address that because it's terminal. And I can't see where you bankrupt the whole family, put them in such a weird space before, during, and after.
Yeah.
Something's got to be done about that. And I'm not sure how to answer these people because they come to me and ask, Doc, can you slip me something? And I'm like, no answer.
Yeah, exactly. I want to say I agree with you that we have to change this. This is probably one of the most difficult ethical issues that we face at end of life, is dealing with those dementia communities, especially when the people with dementia say, I don't want to be here looking like that. It's considered the issue of personhood. Who makes that decision? Who you are sitting here now to make the decision for who you are later, or are we taking care of a vulnerable population? There is no answer right now, but because it's a Medicare definition, and in some other countries, they are actually expanding this and saying, if you see your death in the foreseeable future, you don't have to have this diagnosis. But you're right, with Alzheimer's, it's a terminal illness for a long time, but they can't qualify for hospice until they get to the very end when they're pretty advanced, so they don't technically have a rubber stamp of a diagnosis, and it's incredibly painful. I wish I had an answer for you what to say to them, but nobody around the country does at this point. So they are part of the population that we forget because they sit in between. They sit in the worst possible place I can think of, honestly.
Kim.
Hi.
Hi, Kim. Thank you for your presentation. It's a very important topic for all of us to think about. You mentioned, in addition to the whole dementia issue, that not everybody can participate. And I assume you meant not only because of their diagnosis, but also because there's a significant cost involved. Can you speak to the cost, at least at this point in time?
You know, it's changing a lot. So for a long time, Seconal was the drug of choice, and Big Pharma, and I don't want to talk about where they're going to go after they die, basically raised the cost to about $4,000. So it was really prohibitive for a lot of people. Yeah, it was. We can't get Seconal anymore. And so what's been happening in a lot of places is they're working with a cocktail. It's 4 different drugs. I don't remember what they are. Some people actually prefer it because they can titrate it more to the patient, and it's considerably less expensive. No, but I want to say again, we think of this as this bizarre new thing, but none of these issues are new. Quality health care, being able to afford medication, things that you need, they've always been issues. Excuse me. There's concern on the part of the opponents that it will be easier to get this funded than, say, good breast cancer care. So that's also part of it. So the money piece is still kind of all over the place, although Seconal right now is not going to be a restriction for most people. Yes?
Can you talk a little bit about the challenges between federal law and state law and the predicament it puts some providers in to accept Medicare from the feds and inability to carry through on some of the state law?
I'm just going to repeat what you said. There are issues between the federal law and the state law, and Medicare dollars cannot be used for medical aid in dying. So there are providers who don't know how to be able to provide services without using Medicare dollars. It's been true in a lot of hospices that this has been a real issue. How do we do this when we will get dinged? Now, again, there's 2 things. Medicare could come after hospices. Doctors could actually say to their institutions they're working with, you can't stop me from doing this. But it's not been tested in court yet. So there are the realities, and then there's the reality. But that is one of the big issues, is where do we get our dollars from?
How does this work with advanced medical directives that you may execute while you're compos mentis? Can that be taken into account, or do you actually have to be in full command of your faculties at the time the diagnosis takes place or the decision of your physician takes place.
Well, you know, and advanced care planning is a whole different discussion, which I do a lot of. But in both of those situations, basically speaking, you have to have decisional capacity, basically. Only when you have when you're working with advanced care planning and you have a healthcare agent, their point is that they make decisions for you when you're not able to. Medical aid in dying, if you can't make decisions up till the very last minute. I mean, if you can't make decisions, you can't be qualified. But then,
medical surgical treatment or living will in Colorado law is something that you do at the time you're competent, but you say, you know, if down the line, if two doctors certify that there's no possibility of recovery, that you're terminal, whatever, I mean, that is kind of then you're directing the life support to be discontinued.
right.
So there is that model in Colorado that says, I'm making this decision now when I'm confident that if these circumstances happen, I want to have end of life. I mean,
Correct.
that could be a model that we could pick.
So what I'm going to reiterate really quickly, advanced care planning is usually 2 documents. I'm appointing you to make decisions for me,
That's right, power of attorney.
power of attorney, based on what I'm telling you I wanted. So you're looking at my values, you're interpreting what I would have wanted. If it's not on paper or whatever, you're interpreting my values. When someone's using medical aid in dying, if they get to the point where they can't make their own decisions, or if they get to the point where they change their mind, you can't basically take the drugs in and give it to them because they can't self-administer. That's the tricky part. Sir?
I just wanted to share information. I lost my wife 6 weeks ago.
I'm sorry.
She had signed up for medical aid in dying in July, and the system failed her. And she was in excruciating pain for an extended period of time. And only because of the intervention of a doctor in the Washington State program, the intervention of the head of the Oregon program, and Gary Kahn, did she finally get the Seconal. Initially, she was informed that the drugs would be held for her in a pharmacy. They were not, and we could not get the drugs. And the actual cost of the Seconal was $5,400.
Yeah, 54. So some of the systems have navigators, which is really what you're talking about. And I've done this with my clients. All those death mechanics, all those pieces of putting things together that the law doesn't cover can still create situations like this where things are way too hard and they don't work out the way we thought, which is why I said this is a good starter law, but there's a lot of holes in it and you ran into them and I'm really sorry you had to deal with that.
Anyone else have a question?
One more question? I think I'm over time.
All right.
Kim Mooney, all these many years that I've known you, you are the best at what you do, without a doubt. But Boulder Rotary and myself, we get the last word, which is why I campaigned to do this today. But on behalf of Rotary, we're going to give you, in your honor, 100 doses of vaccine to the Polio Plus Fund. And it is, again, an honor and a privilege to see you today. And thank you very much.
Thank you. Thank you for letting me come.